have to manage obesity. And my job has been made easier. Dr. Sunil Gupta has nicely introduced the molecule. I'm going to deep dive into the SELECT trial. A little bit heavy post-lunch. Let's see how much of you can take it. CVD is the leading cause of mortality in people with obesity, not prisoner of war. It's people with obesity, PWO. And these slides are, canned slides. I think we can quickly pass. If you have obesity, you have increased risk of type 2 diabetes, MSLD, CKD, hypertension, etc. And whichever person you see, type 2 diabetes, about 40 to 60% are obese. If you take people with a MASH, about 80% are obese. People with CKD, 60 to 70% are obese. So obesity is all pervasive, and we need to manage obesity. Until about 3-4 years ago, we did not have good drugs to manage obesity. And as far as we Indians are concerned, we did not have anything till about 6 months ago. So now we have molecule semaglutide 2.4, and that's what I will be discussing. So obesity is a major CV risk factor, and despite current standard of care, there's a residual risk of CV events. In people with obesity, do not get confused. I'm not talking about CVOT in type 2 diabetes. You must have heard those talks 100 times. There are 10 CVOTs with GLP-1 receptor agonists. I'm not talking about that. I'm only talking about people with obesity without diabetes. That's what SELECT trial is all about. So this was SELECT trial. This is the largest CVOT, be it diabetic or non-diabetic patients. The second one which comes closest is the DECLARE-TIMI trial, which had 17,000, about 300 odd patients. And the third which comes closest is the exenatide LAR, which we don't use. So point number one to take home, this is the largest CVOT trial. I mean, is it a good thing, the largest CVOT trial? Probably not. It's a statistical calculation, because these were people with obesity without type 2 diabetes. So the event rates were not that high as expected. This is the SELECT trial design. Impossible to take you through. This slide alone, I might have to spend 5 minutes. I don't have the time. So just read, I made your job easier. I put the yellow boxes. The numbers were 17,000. No prior history of diabetes. It was a superiority trial. If you want, we can discuss in panel what is an inferiority trial, what is an equivalence trial, and what is a superiority trial. To do a superiority trial, the company has to be very solid. They should have enough evidence, because you start a superiority trial and don't get superiority, you're in trouble. So there are very few trials which were superiority trials. If you see the primary endpoint, thankfully, most of the CVOTs, and especially the renal data, they keep changing the goalposts. So it's very hard to compare one molecule with the other. But here in CVOT, thankfully, if you see the primary endpoint, is exactly the same that you had in type 2 diabetes CVOTs, which is 3 PMAs, cardiovascular death, non-fatal MI, non-fatal stroke. And they had 3 confirmatory secondary endpoints. Very confusing. Each trial takes their own secondary endpoints. Here what they did was, they took CV death as the first secondary endpoint. Why we can discuss in panel. Second was heart failure, and third was all-cause death. The problem here is, statistically, if you miss the first secondary endpoint, the statistical significance, rest whatever data you get is hypothesis generating. You cannot say that semaglutide reduces all-cause mortality. You can say semaglutide might be reducing all-cause mortality, but if you get superiority for the CV death, then you can go on. I'm saying this because as you see the results, you will understand why I'm saying this. They were non-diabetic, but 66% of them were pre-diabetic. Mean BMI was 33, the weight was about 96 to 98 kilos. And if you see the distribution, majority were in 30 to 35, 42.5%. Mean GFR, they did not have too bad renal impairment, about 1/4 had chronic heart failure, and we won't go into much details. This slide has already been shown. This is fascinating. In people with obesity, without type 2 diabetes, with established cardiovascular disease, all of them had to have established cardiovascular disease, either AMI or stroke or peripheral vascular disease. We can go into details if you want later during discussion. And there was a 20% statistically significant reduction in 3 PMAs. If you see the confidence interval, 0.72 to 0.9, and they met the superiority. P-value was unequivocally less than 0.001. Now if you come to the right-hand side, semaglutide 2.4 significantly reduced the risk of MACE versus placebo, added to standard of care. I was not able to show you those slides. All of these people had obesity, cardiovascular disease. Majority of them were on statins, they were on ACE-ARB, and they were on antiplatelet therapy, be it aspirin or clopidogrel. So it's not that semaglutide is doing the benefit because patients were not adequately treated. They were all adequately treated. Semaglutide was added on over standard of care. All 3 components, CV death, non-fatal MI, non-fatal stroke, contributed to the MACE reduction. And the effect of semaglutide, again, hard to show you all the data. It was consistent across different patient subgroups. Problem started with the secondary outcome. Here it says if you see, CV death was the first confirmatory secondary endpoint. It shows 15% reduction, hazard ratio 0.85, but look at the confidence interval, 0.71 to 1.01. So it's just missed the statistical significance. So there was reduction in risk of CV death, but that was not statistically significant, but suggests a benefit. Hence, the other two statements which you are reading, 18% reduction in risk for composite heart failure and 19% reduction in all-cause mortality, yes, they were there, they were seen in the trial, and probably, you can use the word probably, that's true, because the first cut missed the statistical significance. Look at the improvement in all the other multiple cardiometabolic risk factors. HSCRP, inflammation, you heard Dr. Sunil Gupta mentioning about inflammation. Inflammation is the buzzword now. You have to get the inflammation sorted. And about 37.8% reduction in HSCRP, triglyceride went down, HDL went up, LDL went up, 0.31% reduction in HbA1c. Remember, 66% of them were pre-diabetics. And reduction in weight, you just heard 18%, right? The reduction in weight in the SELECT trial, which was a long trial, over 3.3 years, you had a reduction in weight was 11.7%. About 6.5 centimeter reduction in waist size, you have to buy a new belt, and reduction in SB, systolic and diastolic blood pressure. This slide is too busy. Whenever you go to, previously you used to hear about CVOTs in type 2 diabetes, right? All these SGLT2 inhibitors, 10 GLP-1 inhibitors, you have seen these tables time and again. Now see the tables again. Here these are people with obesity without type 2 diabetes. Only 6 drugs are licensed worldwide for managing obesity as of now in 2025, of which only 3 are licensed in India. Orlistat does not have a proper CV outcome trial. If you take sibutramine, rimonabant, and locazarine, they're all banned. So no point having them on the table. Phentermine, topiramate, they tried to do a cardiovascular outcome trial, but that was not completed. Naltrexone, bupropion, they did it, but again, if you see, terminated. The red boxes means they could not complete. So prior to SELECT, some of the half-hearted attempts of doing a CVOT in people with obesity without type 2 diabetes did not show any benefit. So you must congratulate Novo that without having any previous data, they went on to do a cardiovascular outcome trial, and that to a superiority trial in people with obesity who were adequately treated with ACE-ARBs, with antiplatelet therapy, and with statins. 3 more trials are coming. So next time when you hear SURMOUNT, which is tirzepatide, REDEFINE, which is CagriSema, and SYNCHRONIZE, which is survodutide. These trials are on. Some of them have 5p MACE. Now that's very difficult. Why they have 5p MACE? I mean, it becomes very difficult to compare later on. CagriSema has got a 3p MACE as an outcome. So semaglutide 2.4 is the only anti-obesity medication. This word was not there in your slide to date. I added to date. The Novo slide said semaglutide is the only anti-obesity medication. Sorry. 3 more are coming. And they are doing the cardiovascular outcome trials. So as of now, I mean, they might fail, I don't know. They might not fail, I don't know. So what I'm saying is, semaglutide 2.4 is the only anti-obesity medication to date. And I think this to date will last for a year, year and a half, or 2 years. So they are far ahead. Their second and third competitor is way behind in a 4 into 100 meter relay. So it will be there for a while with proven cardiovascular benefit in people with obesity without type 2 diabetes. And these slides are canned slides, no need. This was what Dr. Sunil Gupta mentioned, that if you saw the curves, they diverged very early. So day 20, first statistically significant MACE reduction was seen with semaglutide versus placebo. Day 86, that's about 3 months now, first sustained statistically significant difference in MACE reduction with semaglutide 2.4. And this early weight MACE reduction tells you that you can't say that all this benefit is just because of weight reduction. Could be anything, weight, blood pressure, lipids, and on top, I said, inflammation. Because the HSCRP reduction in SELECT trial is one of the highest that you would see in cardiovascular outcome trials. Next question comes, are these cardiovascular benefits of semaglutide 2.4 being observed and replicated in real world? Any meeting that you go, randomized, that we have had talks, right, which is better, randomized control trial or real world evidence? They have some benefits, they have some benefits. Both are required. Ladka bhi chahiye, ladki bhi chahiye, the family will be complete. So randomized control trial, you got the benefits. Does it replicate in the real world? Because randomized control trial, everything is under the control of the investigators. So there are 2 real world evidence data published to date, not published, here has been presented. One is called SCORE. Let's read SCORE on the left-hand side. It was a retrospective, longitudinal, observational cohort study. Moment you hear all those three words, you know, there's this data you have to take with a pinch of salt. There's a lot of bias involved here, but that is the data we have. It's a Komodo research database, which is there in US. They try to select the population. The moment you're trying to select the population, bias comes in, and they try to select exactly the population that was there in the select trial, which was people with BMI more than 27, age more than 45, previous MI/PAD, and no prior history of type 2 diabetes. The interesting part, which will generate a lot of questions, I'm sure later on, is the STEER trial. As of now, you know that the tirzepatide cardiovascular outcome trial in people with obesity without type 2 diabetes is still not out. Summit MMO is ongoing. What has come out is SURPASS CVOT, which also has not been published yet, which is in people with diabetes. So we do not have a head-to-head comparison between semaglutide 2.4 and tirzepatide in people with obesity without type 2 diabetes. So what we have, the second best what we have is the STEER trial. I think Novo beat the other competitive company by coming out with this first. But I'm sure, don't worry, they also must be working and they will be coming out. This is the same story we heard when we compared Glargine 300 with Degludec, isn't it? So many trials were done, real-world data. Each said the other one is other one is bad. So let's see what the SCORE trial showed. Now here again there's confusion. They've used something called revised MACE-5, revised MACE-3. I don't have the time to take you through these, but just to know, overall, there was a 45% benefit in revised MACE-5, 57% benefit in revised MACE-3. This is the SCORE trial. SCORE trial is people with semaglutide compared to people without any other drug being used, just standard of care. What's of interest is the STEER trial. STEER trial is a real-world comparison between semaglutide 2.4 and tirzepatide. Numbers are quite large, 10,000, 10,000. Standard of care was given. Now, difficulty is these drugs were used for 6 months, so the total duration of treatment is only 8.5 months. That straight away tells you that take this data with a huge pinch of salt. You can't have cardiovascular outcomes in 8.5 months. And again, it's a real-world data. It's a match study. Even though they tried their best, there's something called propensity matching, where they match huge number of variables, but there are huge number of variables which remain unmatched. So that's the problem with real-world data. And here, if you see, little difficult to rush through these slides. That's why I put those green boxes on the top. Revised 5P MACE, revised 3 MACE, and 5-point MACE were statistically significantly better in semaglutide as opposed to tirzepatide in 10,000 people in real-world data where they were followed up for 8.5 months. Look at the problem. Look at the yellow boxes now. Look at the number of events. The number of events are very small. So before you leave this hall and say that semaglutide 2.4 is better than tirzepatide with regards to obesity and people without diabetes with regards to cardiovascular outcome, all you can say is there is real-world data which was followed up for 8.5 months, and that unequivocally statistically shows that probably semaglutide 2.4 is better than tirzepatide in people with obesity. That's what this concluding slide says. Superior CV benefits over tirzepatide. Whether it's a molecule-specific benefit or not, 2 question marks were not there. I added those 2 question marks. So the primary endpoint demonstrated a lower risk of CV events with semaglutide compared to tirzepatide, and this supports the growing evidence that CV benefits of sema is possibly molecule-specific. So what were the strengths? Strength of this real-world data was, cohorts were well-balanced, propensity score was used, large sample size of 10,000 patients in each arm, but the number of events were very small. Duration of follow-up, if you see the last line on the limitations, 3.8 months for sema and about 4.3 months for tirzepatide. You can't expect cardiovascular events in such a small time period. Chairperson sir, do I have 3 minutes? Because this is a very burning topic.
Yes, sir. No problem.
So this is a question which is the elephant in the room, which most speakers don't address. So I have put my head and I'm addressing what is called NAION, non-arthritic anterior ischemic optic neuropathy. This is the big noise now. Every meeting you go, before you ask the question, I'm trying to give you the data. This was just presented 2 weeks ago in EASD in Vienna. It's not been published yet. This was the oral presentation. You can see the person presenting if it's coming out, Wilsball. What they did was, prior to this, all you had was case reports. Patient started semaglutide, lost his vision. Patient started liraglutide, lost his vision. What Novo did, now this is Novo generated data. what they did was all the patients who got liraglutide for weight loss, 3.0 milligram, and all the patients who got semaglutide 2.4, they collected all the data and they looked back to see how many of them had NaION. Two busy slides, but if you see this one, statistical analysis, just look at semaglutide trials. Semaglutide treated participants, confirmed cases are 3, unlikely cases are 2. P-value you can see. And placebo-treated participants, 1 confirmed case and 1 case which was unlikely. So 3:1 in a huge number of patients with 83,000 and 64,000. And if you see this slide, they dissect these 3 patients in the semaglutide. On the top 3 are semaglutide patients who had NaION, and the lower 5 are the people in the placebo group who had NaION. Difficult for you to read this whole table in such a short time span. All it tries to tell you is this was properly done. 3 ophthalmologists went through all the data, and they said that there's no pattern in time to onset of the event that was observed, and most ophthalmic confirmed cases reported had many confounding factors. NaION does not happen with a molecule. People with diabetes, hypertension, smokers, people on a few other drugs can get NaION. So this is the latest data that you have. So those of you who are prescribing semaglutide 2.4, can I see by a raise of hands how many of you are prescribing 2.4 for weight loss? So now, because I was hesitant to prescribe, I'm being very honest. Now when I have this presentation, I can tell my patient, boss, it may cause, but now I have data which I can share with you that there was no difference in the semaglutide arm or the placebo arm. Prior to this, there were case reports, there was noise. And I think during question answer of this, we'll also discuss. There's a lot of what's called, inverted commas, Twitter noise on NaION. So that's my conclusion. This safety evaluation of all completed randomized placebo-controlled trials evaluating Lira and Sema conducted by Novo supports NaION being a rare event. You can always say, Dr. Mukherjee, conducted by Novo. Yes, fair enough. If any of you is interested, you can go to the data, and then you can come up with the data. It will be nice. The data do not show an increased incidence of NaION participants randomized to Sema or Lira treatment versus those doing placebo. These data do not suggest a causal relationship. It's an association. It's not a causal relationship between Sema or Lira. Is it absolutely true? Don't know. You need a randomized controlled trial to say it's absolutely true, but this is the best data that you have, and this is a huge database, and I don't think Novo will come up with something which they can't justify. So last slide. Despite standard of care, people with obesity, they have a cardiovascular death. Just like we used to say people with diabetes, 40 to 60% have a cardiovascular death. People with obesity also have a cardiovascular death, not osteoarthritic death, not a OSA death, not a pulmonary death. 60 to 70% of people with obesity, person you see tomorrow with BMI of 25 or 27 and above, he's going to have a cardiovascular death. No matter whatever you do, you give statin, you give beta block, you give your ACE inhibitor, you give your aspirin, antiplatelet therapy, there's a huge burden still left behind. Semaglutide 2.4 is the first, until date, the only anti-obesity medicine with a proven 20% MACE reduction in people with obesity without type 2 diabetes. CV benefits seen with Sema start soon after initiation, suggesting these benefits are mediated by factors probably beyond weight loss. And Semaglutide 2.4 showed consistent CV benefits across real-world data as well. And the STEER data probably might be suggesting that maybe semaglutide 2.4 is better than tirzepatide. We need a randomized control trial for that. With that, I will stop. Sorry for exceeding by 3-4 minutes. Thank you.